Thank you very much. It's indeed an honor and pleasure to be here, and I'd like to congratulate Harry and Ian for their awards tonight. I'm going to give you an update on our biomarker experience at UCSF, but first, I'll tell you about the California fires. If you had looked at the Santa Rosa Press-Democrat 5 days ago, you'd have seen a picture of my truck here on the right-hand side. And on the opposite side, you'll see where my home was with these fires coming from right and left. Well, the fire wasn't done with that truck, and that was the final picture. I actually snuck behind the evacuation barricade in the back row to see my property. Interestingly enough, the fire came within inches of the home twice. So there was a major firefight at the home. Neighbor's house lost, the other neighbor pristine. And these hoses, they still left around my home. It's remarkable that it still exists. There was a carport and sheds around this truck, totally vaporized. It had 2 carbon fiber bikes, which are near and dear to me, which are gone. Now, luckily, I have a new truck I'm going to pick up when I get back to the city on Saturday to try and start rebuilding. So prostate cancer in 2017, many new tools, both pre-diagnosis, after diagnosis, who gets surveillance, if you're treated, what's your risk of recurrence, and if you get treated in an adjuvant fashion, what do you do at the time of relapse? And I'm going to go through just some examples of UCSF on how we're using these new biomarkers, which are both imaging-based and molecular-based biomarkers. Now, I knew Andrew was going to talk about the pre-diagnostic space, and I'll just show you our experience at UCSF in this space. I lead the NCCN Early Detection Panel, and clearly this year, this whole movement towards improving the specificity of PSA testing. It is true that if you have a PSA above 3, you get a biopsy, you reduce prostate cancer-specific death rates, but you do so at the risk of overdiagnosis. So this year, we were quite clear on this, that in fact, you could consider a test of specificity. And like Andrew said, you'll confront this issue of the 50 to 60% false positive rates and over-detection rates, I say, of 20 to 40%. It may be as high as 50%. And this is our experience in patients who underwent MRI and 4K. I can tell you the controversy right now is, what do you do? Do you do a 4K prostate health index, MRI, or do you do the combination of tests? And that's what people are currently wrestling with, is what test of specificity do you do, or do you need to do both? This is several hundred men who underwent biopsy, and I'm showing you the experience. Again, the way I like to look at this is that biopsy is avoided and the significant cancers missed. Now, by significant cancers, most of these are 3, 4 cancers. These are not high, Gleason 8, 9, or 10 T3 or T4 cancers. They're Gleason 3, 4. So both MRI, using a cutoff of PI-RADS 4 or 5. Many people will biopsy all MRIs with PI-RADS 3 or higher, and I don't know what the experience here is at Memorial, but this is looking at PI-RADS 4 or 5, 4K greater than 7%, and doing the combination of tests. And again, you'll avoid a significant number of biopsies and miss very few cancers. And the cancers you tend to miss are these Gleason 3, 4 cancers. These are just the area under the curves here. You see the PSA in blue is not very good. PSA density does a bit better, but by combining tests, you'll do even better. My sense is, going forward, you'll do a serum test first, and then you'll consider, based on risk, whether or not you do an MR for an MR-targeted biopsy. Insurance companies sometimes give us problems with that, but that's generally been our approach. What about after diagnosis? A key principle here, which I tend to want to emphasize, that any new marker has to improve on existing multivariable clinical models, ideally a previous validated one. No offense to Anthony D'Amico, NCCN risk groups, the AUA risk groups, but these are simply not adequate to properly describe prostate cancer. There are nomograms. Of course, we're a big fan of the UCSF CAPRA score. Easy to calculate, don't need pen and paper, don't need a computer, 0 through 10 score. It's been validated around the world in tens of thousands of patients, multiple continents. And again, it's the bar is high for improved accuracy. This is PSA-free survival following surgery. I could show you the same thing for radiation therapy. It also predicts, interestingly enough, for prostate cancer-specific mortality and overall mortality. So it's a very good instrument, and I think is a baseline to which you compare other new markers. What's ideal endpoint for these tissue markers? Something we wrestle with: metastases, biochemical recurrence, PSA kinetics. We sit in this space of active surveillance, so there's a whole issue of progression on surveillance and this issue of adverse pathology. If you have a low-risk patient, you take them to surgery, what's the likelihood that you actually missed adverse pathology, which is primary pattern 4 or 5 or T3 disease? A lot of commercial tests. We've worked with all of them. We have publications in all of them. I think they all do pretty much the same thing, and I think they generally quite correlate well with one another. I'm just going to show you one example. There are many examples. I have no financial interest in this one. This is the GPS score. Again, a 17-gene RT-PCR assay. Again, it works on 1 to 2 millimeters of tissue. It's actually fairly robust. And the important point here is I'm showing you there's a weak correlation between CAPRA and the GPS score, and that's exactly what you want to see. You want to see a weak correlation. If it correlates well, then it's not a valuable marker, because you already know what the risk is. And this just an example here is I'm showing you who these are people who on biopsy all had low-risk disease, and I took them to surgery. So we have a big tissue bank at UCSF in which we could do this. And this is their CAPRA scores and the likelihood of favorable pathology based on the CAPRA score. If you add the GPS score to that, what you do is you get a further refinement in actual risk. So with any individual risk group, you can move that risk up or down by adding the GPS score. And our sense is that you'll probably increase active surveillance rates by 25 to 40% using a biomarker. Now, this is an update that we've submitted on use of the commercial assay GPS. Again, we've done this with others, but this is a GPS commercially, and what I'm showing you here is for men with Gleason 3-3 or 3-4. We have a fair number of men with 3-4 on surveillance at UCSF. Did the GPS score predict for progression? And the answer is yes, only in those who had 3-3 disease, not those with 3-4. The median GPS was actually 24. If you look at the prediction of adverse pathology, it also works. And again, in 3-3 disease, for each 20-point increase in GPS, you double the risk of adverse pathology. A good rule of thumb here is to think of a GPS score of about 30, and that defines, doubles the risk of progression or adverse pathology overall. So again, in our commercial experience with this assay, it seems to work well in those with 3-3 disease. Now, one of the problems we have is that these are very expensive markers. They may have value, but they're quite expensive. And so one idea that we had is, there are many available, they seem to add value, they're all expensive, is there an alternative? So our thought was, can we use IHC as a way to have a low-cost alternative to these genetic tests that might actually predict outcome that could be available anywhere in the world at much lower cost? So actually, I did have about 424 patients who underwent surgery where we had a CCP score on them, and then we made an array and we looked at expression status of P10, ERG, and Ki67. And then this is the result. So for predicting the risk of recurrence, the CAPRA-S, Polaris did better. The C-index is relatively good, and if you look at the bottom one, the CAPRA-S with the triad loss of P10, high Ki67, positive ERG, in fact, that performed relatively well as well. Not quite as well as the GPS score, but did rather well. There were actually 112 recurrences of this 424 patients who underwent surgery. Now, there were 28 patients who had metastases, so we look at comparison to 3 Cox models for metastases of prostate cancer-specific mortality. Actually, P10 and CAPRA-S is a very strong predictor of metastases. So in fact, it suggests that maybe use of these IHC markers is an alternative to a more expensive genomic test. I asked Samson Fine, I couldn't find what it cost at UCSF to do these. I was worried that it might be another $6,000 to get a pathologist to do this. He assures me it's going to be much less than that to do these tests. So this suggests that in fact, that we may have alternatives to an expensive genomic marker. What about MRI? Now, interesting enough that there is, when we look at MRI versus genomic markers, we see very little correlation. Even though the most may be predictive, they tend not to correlate, which suggests that either we're not getting as much information from the MRI as we should, or in fact, they give us different types of information. So again, looking at the MRI, again, in the same thing to predict progression on surveillance, or adverse pathology, PIRADS-5, not a PIRADS-4. PIRADS-5 is a strong predictor of progression on active surveillance, and there's a trend towards a predictor of adverse pathology in those who underwent surgery. What about predictive biomarkers? Again, this whole issue of what do I do after I've done surgery? We have a high-risk patient. Do I go ahead and give radiation, hormonal therapy, or combination? And this is work from Felix Feng, we recruited to UCSF. It's been a great recruitment to UCSF, showing you using the Decipher score that, in fact, if you use Decipher score to identify patients at higher risk of recurrence, but those with high Decipher scores may benefit from early adjuvant radiation rather than salvage radiation. The reduction in metastases was about 80%. He's gone further on this, and if you go ahead, when you order your Decipher score, you get Decipher grid, you can actually get this Porto score, which we're looking at very carefully as a predictor of radiation response, that a high Porto score suggests that those patients would benefit from the use of adjuvant or salvage radiation therapy. Well, very interesting, Felix has also done, and I'm not sure this is out yet, but is certainly in press, this whole, like in breast cancer, these luminal A and B, these basal subtypes, may be very predictive of outcome. And he did the same thing, PAM50, in prostate cancer patients. And again, he found that these luminal B had the worst overall outcome, but in fact had the most significant response to androgen deprivation therapy. Now, whether this is a predictive biomarker or you're just predicting adverse outcomes is unclear. So is it prognostic or predictive is unclear, but I think we're moving towards predictive biomarkers rather than prognostic biomarkers. What about biochemical failure? I can tell you this is a patient that Dan Lin and I share. The PSMA PET imaging has had a profound impact on how we manage prostate cancer, and certainly a profound impact on my understanding of prostate cancer biology, metastases, and the state of disease. We've used it both, I'm not going to go into great detail here, we've used it both before diagnosis in high-risk patients, we have a trial for that, and we're doing it in those men who fail biochemically after surgery or radiation therapy. What I'm showing you here is an update in 160 men who failed after surgery. Now, some of these men did have adjuvant radiation therapy, a small number did. And I'm showing you here the positive PSMA rates at various PSA cut points, down between 0.2 to greater than 6. So at a PSA cut point of around 0.2, about 40 to 45% of men will identify a site of relapse. If we look at the sites of relapse, we see the prostate bed is an unlikely site of relapse. Even though it's commonly thought to be a common area, that these patients are generally marched off to radiation therapy for biochemical failure. In our experience, the prostate bed is an unlikely area for relapse. Now, all these men also underwent ultrasonography at UCSF, and we have an excellent sonographer who actually is quite good at detecting these early prostate bed recurrences. And if you look going forward, that the pelvic lymph node, that these patients fail in the pelvic lymph nodes are in green there, and the red is the generally retroperitoneal nodes. But we've seen PSMA PET active disease. I had a patient I operated on 20 years ago, could never find where his recurrence was. Single paratracheal lymph node, biopsy proven, he got radiation therapy. I have another patient, again, that were late recurrence, a lung metastases, biopsy proven, and we're going after these aggressively to see if we can increase the time to metastatic relapse. But this is eye-opening for me. The other thing I want to point out here is that 40% of the lymph nodes identified in the pelvis, either before or after or outside the primary landing sites for when we do surgery or when we do radiation therapy. So these are perirectal nodes. Very commonly we see them. So I think there may be a new paradigm here. I don't want to be heretical here, but in fact, this idea that we'll just simply, with the biochemical failures, march people off to radiation therapy, I think you have to think a little bit about that. Again, the response rates is only 50% at best, and there is side effects of salvage radiation therapy. So again, I think if you have a margin positive, high Decipher, consider going ahead and giving adjuvant radiation therapy. But for the margin negative patient, other features not predictive of radiation response, I'm waiting on these patients. The FDA allows us to do imaging at a cut point of 0.2, but I'm letting these PSAs rise a little bit now to 0.2, go ahead, do the PSMA, find the site of disease, and try and target it better, identify the site of relapse. The future in biomarkers, I think this has evolved very rapidly. This is our work. Matt Cooperberg is leading on this. This is again, this is all an Illumina chip here. This is a genomic landscape of low-risk disease. It's actually much more complex than we once thought. We're seeing a lot of complexity here, and I think we'll see a new round of genomic profiling. I'd also like to acknowledge Dan Spratt here. We're part of this trial. What Dan did, he assembled 4 large cohorts. Dan's a radiation therapist at Michigan, works with Felix. 4 large cohorts, again, using the NCCN risk grouping, which is very commonly used, not CAPRA, but NCCN. What he developed is a genomic classifier, and add the genomic classifier to the risk groups. He came up with a 6-tier and a 3-tier clinical genomic risk profile. This is in press currently. And what he shows is that the C-index for metastases is much improved using this combination clinical and genomic landscape. And I think, again, this is a further iteration on the idea how we can use genomics going forward. And what it shows is you can take the NCCN risk groups, very low, low, in this intermediate, favorable, unfavorable, high, very high, and combine it with the genomic landscape, and in fact, maybe better select patients who might undergo active surveillance versus radical therapy. And again, all these slides are courtesy of Dan Spratt. We're taking this a little step further. Again, in closing here, is what we're doing now is we're imaging these patients before surgery. We identify these nodes, we take them right out, we put them in these PDX tumors, which allow us another round of ability to, again, interrogate these. So we have these animal models now that I think better capitulate the individual tumors that we're taking out in these higher risk patients. Our pattern's changing. I appreciate Andrew showing the Memorial experience. This is through 2015. You can see that when I started in urology, the ideal patient for surgery, the ideal patient was a T1C, T2A, Gleason 3-3 patient. That was the ideal patient. You operated on that patient. If you had a high-risk patient, you simply marched them off to radiation therapy. And you can see at UCSF right now, less than 8% of our patients have Gleason 3-3 disease who undergo surgery. And I think those are the 3-3 genetically aberrant tumor I was talking with Samson about, the high genomic abnormality, the P10 loss kind of patient. Alternatively, with surveillance now, we've tended to accept more patients with these so-called intermediate risk tumors. So these are generally Gleason 3-4s, small pattern 4, non-cribiform pattern 4 are the ones that we think might be candidates for surveillance, genomically bland patients. So conclusions for the questions is refined risk assessment leads to refined treatment. Use of multivariable models is better than using simple classification schemes. Emerging biomarkers offer improved prognostic information compared to clinical parameters alone at diagnosis and after treatment. Whether these tests are cost effective or not has to be determined. I think they will be. And I think very importantly, how do we integrate one with another? How do we integrate 4K, MRI, things like this? And I'd like to thank my colleagues at UCSF and Dan Spratt at Michigan. Thank you very much.